Okay. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3. Good morning. This is Dr. John Bennett, broadcasting from sunny Miami Beach. Here in the background, Neurosurgical TV. We have the honor of having a frequent visitor to this forum, Sarath Munasinghe, a neurosurgeon from Sri Lanka. He's done a lot of these webcasts, and he seems pretty passionate about it. He just told me he's in a part of Sri Lanka, in a province where he's covering a lot of people. Welcome, Sarath. It's all yours.
Thank you, John. Thank you very much for giving the opportunity, as always. So, good morning, good afternoon, good evening, wherever you are, and welcome to another episode of Neurosurgical TV. And this is Sabaragamu chapter, because I am covering the Sabaragamu province as the only neurosurgeon in that province. So I'm bringing you all these cases, which I have done for the last few months, of patients from my province, Sabaragamu province, which drains, and as the teaching hospital, my hospital is teaching hospital Ratnapura, which drains around 2.5 million of population. So let's start the proceedings. Let's share my screen with you all. I hope I am audible and you can see my screen, right? Thank you.
Yes, check on both.
Okay. Thanks. So, so today I'm going to talk about a few interesting cases that I have performed during the last few months. And it's going to be a very brief and a short presentation, not a lengthy one. So in a nutshell, so this is what we are experiencing most of the time as neurosurgeons in the periphery in a resource poor setup. Unfortunately, as you understand, I have been giving these, nagging speeches on resource poor setup, on how to tackle these problems, the everyday struggle as a neurosurgeon in a periphery. So I hope that I'm being able one day to give you a talk on the robotics or high tech topics in near future, rather than speaking to you all on how to tackle with the poor resources and what are the tips and how to survive these, extreme conditions as a neurosurgeon. But to be honest, this is the real life situation for a neurosurgeon in peripheries in a country like Sri Lanka, where most of the time, even though you know the things, you have the skill, but unfortunately you are ended up in a place that you are being restricted due to the lack of the resources. So most of the time you feel very uncomfortable, and then you start frustrating, you start disappointing, and then you try to change the system, which is not very practical, and then you blame the system and you want to leave the system. But fortunately, we haven't come to that point as neurosurgeons yet in Sri Lanka. But considering the way the things are leading into, I think, I believe very soon things are not going to be that good, because we don't have even the basic, the facilities, even the antibiotics, even the anesthetic drugs. And one day the drills are not working, the perforator is not working, then the next day the cutter is not working. The basics are not there. We are not looking for hi-fi things like S7 navigation system or robotics, or we are not trying to do all lifts, X lifts, or anything like that. But the basics are lacking. So this is causing so much stress on us. And on top of that, it's not only the resources. It's being, there are certain things like the people are ungrateful, a lot of backstabbing, a lot of criticism, So many things on top of that, making our lives very, very miserable. So unfortunately, we have to survive. And as a neurosurgeon who have served the poor people in the periphery for more than 4 years, I have learned few tips on how to survive in the most extreme, most difficult circumstances. And I'm sure it will be useful for young generation, for young people in most of the third world countries. So we have seen neurosurgeons talking about through this forum on hi-fi things, on neurosurgical techniques and the principles and the theories. But it's very seldom we see people are talking about these the resources and the facilities and the basic facilities, because it's not actually a problem for them. But unfortunately for us, it's a major restriction. So in a nutshell, if you consider my country, these are the basic, the drawbacks where I see as obstacles as a neurosurgeon in his daily agenda. So most of the time, the public is ignorant. So they are ignorant about the neurosurgical procedures. They don't know about neurosurgery. Not only the public, even the doctors, the healthcare personnel, their understanding and the knowledge on neurosurgery is very poor. So they can be easily misled. So, I mean, anyone, especially quacks, can mislead them and take undue advantage. And that is what is happening most of the time. So most of the people, they have the misbeliefs, and they have a big fear of surgeries. They don't want to go for surgery when the surgery is indicated, and however much we try to convince them. So for example, if you tell them that you need surgery for a certain condition, they prefer for non-invasive treatment options such as native treatment or some remedial treatment. They are very fond of magic. They are very fond of curing their illnesses, getting cured the illnesses by a single tablet or by applying some ointment or an oil, which is not going to happen in real life. So my main aim as a neurosurgeon, I mean, when I started my career as a peripheral neurosurgeon was to enlighten the ignorant, to make the public aware of the neurosurgical procedures, the setup, and what we could do, what we could offer them, what conditions we could cure. So I'm always trying to enlighten the ignorant and making the public aware by the awareness program. So that is my prime objective. Even when I do some presentation or whatever, an interview, I always try to make the public aware and to relieve their fear, to make them more educated, and ultimately lead them for a better outcome when they have a neurosurgical condition. So this is what we are doing as the peripheral neurosurgeon. We need to work at our maximum capacity with the minimum available. So always I believe you need to work according to the principles without violating the neurosurgical principles, because wherever you go, the principles are the same. Principles are principles. And the patient safety is the priority. That is the key. And also we need to keep in mind that the patient outcome is the ultimate goal, whatever you do. It is, I mean, it's not worth of having a beautiful image, a post-operative image, unless the outcome is poor. So at the same time, your X-rays, your post-op CTs might not look fantastic, might not look beautiful, but the patient outcome may be good. So similarly, we need to think about the patient outcome as the ultimate goal. So for us, we need to adapt and adjust accordingly, depending on the available resources. So we might need to change our tactics and change our techniques depending on what is available for you. For example, if we talk about degenerative cervical spine or degenerative lumbar spine, laminectomy is not always going to be the only choice. If you don't have anything, then it is going to be the only choice, but it should not be. If you don't have, when the fixation is indicated, if you don't have the screws, the pedicle screws, lateral mass screws, I mean, you're ending up only with a laminectomy. But so how are we going to tackle these problems? So this is what we have done. And for example, sometimes we do have the ACDF cages, but the proper sizes are not available. In that case, we had to go for iliac wrist grafts and the fibular grafts as an alternative. So let's see some of the cases I'm going to illustrate. I'm going to explain you with some of my cases. So as how we have managed to overcome these problems. It's not always, but most of the times. So this is one of the cases where rational decision making is very important depending on the resources as a neurosurgeon. So this is a case of a 55-year-old male who presented with severe cervical myelopathy with OPLL. And this is how he presented. He had a very high, very low, very severe myelopathy with high neuric grade and low JOA scores. He couldn't even, he could hardly walk. And this is his, the axial MRI. You can see very thick OPLL. So spanning through C3 to almost C5. So in this case, I'm sure you will agree with me, laminectomy alone is not an option, because you can see the lordosis is lost, and laminectomy alone is not going to be the best option. So if I were to plan a posterior fixation, because in my center, I don't have lateral mass screws or pedicle screws. I haven't had this for last 3 years. So the patient need to buy this. So if the patient were to buy this is 2 years back. So at that time, the cost of a single screw was around 21,000, but now it is around 32,000 Sri Lankan rupees. So at least you will agree with me that you need to fix from C3 all the way from C3 to C7. So at least 8 screws were needed along with the 2 rods, which will cost around 200,000 Sri Lankan rupees. So if I were to do an anterior approach, anterior corpectomy, I know it is not going to be the ideal, because it's going to be, if I were to offer the corpectomy, it's going to be at least 2.5, almost 3 level corpectomy, which is not ideal. So in that case, then the total, the cost would have been around 85,000. So I had to decide, this patient could not afford more than 80,000. So in that case, I had to think about, rather than going for a posterior procedure, posterior fusion, I had to go from the anterior aspect. So this is what I had to do. I had to do almost a 3 level corpectomy with a mesh cage and the anterior cervical plate and fusion. So this is the post-op CT, and the patient did really well, but it's not the it would have not been, I mean, it's not the ideal. So I had to adapt my techniques depending on the circumstances. I would have liked maximum of a 2 level corpectomy rather than a 3 level corpectomy. Fortunately, this patient could afford at least the cage plus the anterior cervical plate. In most of the circumstances we see, I mean, most of the patients, they even cannot afford at least 50,000 rupees. But nowadays, due to the economical crisis, the prices have gone up. They are sky high, so causing a lot of burden to the people, as well as to the causing lots of stress and undue anxiety in neurosurgeon's mind as well. This was another case, another young male presented with cervical myelopathy due to OPLL. Here you can see in the CT there is 2 level OPLL spanning 2 levels, mainly C4 and C5. Here also I had to consider anterior approach, considering the affordability of the patient. So you can see the disc osteophyte complex as well as the OPLL. Usually in OPLL, I prefer anterior approach if it is less than 2 level, it's 1 or 2 levels. If it is more than 2 levels, I prefer the posterior approach. So this is 2 level. So I did the 2 level corpectomy with the cage, the mesh cage, and the anterior cervical plate, and the patient did well. So that was not a problem, considering the pathology of the disease. So this is another case of OPLL, again operated anteriorly, and this patient could not afford a cage. So I had to take the a graft from the fibula. So I have done several cases. I have used fibula as a corpectomy graft, and I think it is the best graft, and it's a very, very good. It shows very good fusion. So I have had very good outcomes using fibula as a corpectomy graft. So this is again a 2-level corpectomy with the fibula graft. Again a 2-level corpectomy with the fibula graft with very good fusion at 6 months and 1 year. Again another one, 4-5 corpectomy, again fused with the fibula graft. It heals very nicely. This is another case of a young male presenting with 1 out of 5 power of the bilateral lower limbs. If you can clearly see, there is a lesion causing pressure anterior to the thecal sac, anterior to the cord, spanning from C4 level all the way down to C6. So in this case also, I did a corpectomy and fusion with the fibula graft. So this is after 6 months, signs of healing was there, and this is almost after 1 year. So very good healing. So this is the patient. So his bilateral power was 1 out of 5 before surgery, and this is few weeks back in the clinic. He could walk without any trouble. So when you consider the outcome is fantastic. Again, another case, another patient with cervical myelopathy, severe cervical myelopathy. You could see the compression is from both anterior aspect as well as the posterior aspect. So this patient had, if you see carefully, his the cervical cord diameter, the spinal diameter is less, so he had congenital cervical stenosis. On top of that, the disc osteophyte complexes causing severe myelopathy. MJO scores less than 8, and he had lots of social issues. He had poor family support. He did not have any, you can't say anybody. He didn't have much support from the family to look after him. And so considering the pathology, so I thought he needed both anterior and posterior decompression. But unfortunately, this patient could not afford any hardware. So fortunately, we had some ACD cages. for this patient. So I decided to operate him both anteriorly and posteriorly at the same go, because according to him, he was from far away. He had to travel more than 150 kilometers to the hospital, so which cost him around 30,000 Sri Lankan rupees. And considering the poor family support, so coming back twice to the hospital is a difficult task. So we did the same, both the anterior and the posterior decompressions at the same time. So I did the 4-level ACDF in this patient. So as I said, if I am performing more than 2-level ACDFs, I prefer anterior cervical plate, but unfortunately this patient could not afford. So we had to do the ACDF only without the anterior plating. At the same time, did the laminectomy as well from C3 to C6. So the whole procedure took only around 3.5 hours to 4 hours. So this is the pre-op. You can see he couldn't even stand up without support. And this is him 1 month back at the clinic, and he can walk independently after 3 months of surgery. So it's very satisfying to see. I'm sure it's not the ideal procedure to be done, but considering the circumstances, I think considering the outcome, we have done a good job. I have done a good job, and I have done a reasonable job to make him better, to make his outcome better. So another case, this one we did 2 weeks back. Another lady, 54 years old lady, fallen from a height, presenting with C5, C6 unifacet dislocation, severely degenerated spine, and she's a known patient with systemic sclerosis, with skin changes, and she had lung fibrosis with a restricted pattern. But according to her, she has a history of satisfactory wound healing, which was a plus point for us. And during those days, our MRI machine was out of order, so we did not have the opportunity to get details from an MRI. She had incomplete neurology. So the decision for me, so the question for me was whether to go from anterior approach or posterior approach for this patient. Because if you go from anterior approach, there is a risk that this patient could end up in lung complications, which you don't want to happen. But wound healing wise, the anterior approach is better. If you consider posterior approach, one thing, you don't have the MRI, so you don't know whether there is a disc, number one, and the incision is a bit bigger, and you are dealing with the muscles as well, the posterior back muscles, and the wound healing might be a problem. At the same time, the lung complications may be less with the posterior approach, and it's quick. So considering all this, she had a good history. She had a history of good, satisfactory wound healing. Although there was this concern about the disc, I decided to go posteriorly. And we did the posterior. She could afford the hardware, so we did the lateral mass screw fixation. This is the pre-op CT, and this is the post-op CT. We did the decompression. The cord was under tension, and the reduction, the alignment we could achieve. So this is the axials, and she recovered very well. And her power was almost 5 out of 5, the lower limb power and the upper limb power. The problem was with the hand grip. The hand grip was around 3 out of 5 on the right side. She remarkably improved, and we kept her in the ward until her wound was healed. And after 2 weeks, we discharged her home. So again, I think you have to be very careful about decision making, especially in spine surgery, because we know in spine surgery, our main aim is the patient outcome, make the patient better, not to harm the patient, according to the neurosurgical principles. So decision making is the most important, one of the most important, the initial step in spine surgery, according to my opinion. Right. So this is just to show you, we have done C2, C3 fixation. This is an atypical hangman fracture of a patient. We did C2, C3 fixation. He couldn't walk. His power was 2 out of 5 initially. Now he's walking. He's absolutely fine. This is after 6 months. We have done C1, C2 fixations of a young girl who presented with a Jefferson fracture. She's doing absolutely fine. We have done, when the resources available means patient purchase this, patient purchase the hardware. So affordable patients can see stenosis at higher cervical spine. We have done OC fixations, but all these OC fixations, unfortunately, we did not have adequate length C1 screws. So that's why we haven't done C1 fixation. We have done C2, C3 fixation to the occiput. Again, similar scenario. See the stenosis. We have done basilar invagination cases, C1, C2 fractures, and we have treated them with OC fixation. And this is an expandable type of expandable cage provided by the Ministry of Health, provided by the government to us. So I had a few of these expandable cages. I used this 3 times, but I'm not very satisfied with the outcome, because almost all the 3 cases, the upper cervical screws loosened up, and I had to revise this. I had to revise the construct. So 2-level ACDF we have done. We have done anterior cervical plating as well, but I'm sure it's not essential to plate 2-level ACDF, but once it's available, if it is indicated, I have done. 3-level ACDF, unfortunately, patient could not afford, so not plating was not done. Again, 3-level ACDF, patient couldn't afford, it was not done. 3-level ACDF, patient could afford, plating was done. And always we try to render a proper service. We try to do a proper job when the resources are available, as I said, as I already mentioned. So we have done hybrid type of procedures with corpectomy cages and ACDF, corpectomy and ACDF at the same time. And again, corpectomy and multiple ACDF, but here we did not have adequately sized or adequately sized, adequate length was not available of this anterior cervical plate. So we have plated only the lower part. So again, the hybrid type of procedures, ACDF plus the corpectomies plated. Posterior cervical fusion. I'm sure you all agree with me that you don't need to fix all the levels bilaterally, depending on the patient's availability. We have fixed both the levels accordingly. C2 on one side, C7 on one side, single side. Yeah. So I feel difficulties and drawbacks makes you a better surgeon. For example, I have got the theaters from 8 to 2 p.m. So I need to finish up the cases before 2 p.m. most of the times. So time is a limiting factor for me, and considering the caseload as well. So you need to clear. It's a burden for us. You need to clear the cases. So you have to think about the time factor as well. I am sure time should not be a problem for a surgeon, especially a neurosurgeon. But if you can do it quickly, if you are skilled enough, that's good. For example, I have done 3 thoracolumbar long constructs from 9 p.m. to 2 p.m. So usually the rough time, the duration for a single thoracolumbar duration from skin to skin, now I can finish in less than 1 hour. So difficulties and drawbacks sometimes make you a better surgeon, sometimes a better and a skilled surgeon. So you need to be patient. You need to stay focused and calm and grab the opportunity and get the maximum out of that. This is another case of a 34 years old male who had undergone C6, C7, ACDF 5 years back. You can see he had undergone C6, 7, ACDF, and this time presented after road traffic accident with C5, 6 unilateral dislocation and with incomplete neurology. He was an affordable patient, making my life easier. So we did the best we could offer for him. So this is the MRI, the sagittals. You can see the cord edema here at the level of C5, C6, and there is cord compression at the level of dislocation. So this is what we did. So you can see the pre-op X-rays. There is dynamic instability in this patient. Can clearly see that. So this patient needed both anterior and posterior approach, according to my opinion, because you can see the ligamentous injury posteriorly. So we did both anterior and posterior fusion at the same day. This was done 2 days back. So lateral mass screw fixation. The lower level, one was lateral mass, the other was a pedicle screw, cervical pedicle screw, and anterior plating, anterior fixation, ACDF at 5-6 level. And this is the previous ACDF, the cage, and I plated both the levels. So let's see the post-op CT, the sagittals. If you consider, if you compare the pre-op and the post-op, a satisfactory alignment and the reduction is there. So that's the sagittals, and let's see the axials. So see the lateral mass screws with the correct trajectory, and see the trajectory of the pedicle screw. It's not very easy to put a pedicle screw, cervical pedicle screw, without navigation. I'm sure you agree with me. It takes a lot of precautions and it needs skill to place a pedicle screw without a navigation. So I'm sure it is very satisfying to put a cervical pedicle screw, a thoracic pedicle screw without navigation, and seeing that everything looks fine and the patient is doing better. So the post-operatively, patient is walking on the second day, and he's 5 out of 5 power in both upper and the lower limbs. Unfortunately, I couldn't get a picture, a photo of the patient. And so I think that is the satisfaction. Now, when we compare, when you have all these hi-fi technology to assist you, to make your life easier, for example, can say a thoracic pedicle screw or a cervical pedicle screw. I mean, compared to that scenario, if you don't have that that facility, that infrastructure, so you are merely working with your timing, with your knowledge, with your experience, with your skill and everything, and you get the things right, I think it's very satisfying rather than going with all these hi-fi technologies. But if you have the technology, you need to use this. It's better to use this because patient safety is number one. But what I'm telling you, even if you don't have this technology and the facilities, sometimes it can make you a better surgeon, because then you know you can work anywhere in the world without any doubt, with such great confidence. Right. So another aspect I would like to bring to your attention is short segment fixation of thoracolumbar fractures. So for thoracolumbar fractures, I am sure we can go for long segment fixation as well as short segment fixation. But for me, my main aim is to get the maximum stability, get the maximum strength with the minimum number of pedicle screws, depending, because one of the major problems for us is the lack of this hardware. So for me, I have had good outcomes up to now. So I can show you more than 50 cases of short segment fixation I have done only during this year, 2022. So lots of patients we are getting with fallen from height, especially fallen from trees, because Ratnapura is an area which is famous for gem mining. So there are gem mines. So most of the times patients fall from these mines from 50 to 60 feet height. And at the same time, there are a lot of tree climbers. So they fall from these trees and they end up with the thoracolumbar fractures. It's very frequent. So I am getting so much thoracolumbar fractures and other fractures due to the falls from heights. So what I do is, so if the pedicle is not disrupted, if not blown out, I fix the fractured pedicle as well. Most of the times, if you fix just one pedicle of the fractured segment, that's enough. And also, I would like to use at least 5 or 6 pedicle screws, and 4 screws are not enough, according to my opinion. You need at least 6 pedicle screws. Ideal would be 6. So if you want to extend, you need to go higher up rather than going down. So which is very obvious. So here, the patient could afford only 5 screws. So I had used 5 screws, and the fracture segment unilateral fixation was done. So many cases I can show you the same principle. Here, both the fractured pedicles were fixed. Here, the unilateral fixation, can see so much. I can show you more than 50 if you want. Same principle, and up to now, very good outcome. So all these fixations were indicated. Not a single case was not indicated. I usually go with the T-Lix score, and I always go with the T-Lix score and the AO spine principles and the classification. So there are so many cases where we have managed with the thoracolumbar corset with the conservative management as well. So only if it is indicated, I opt for fixation, because one of the major obstacles in my practice is the affordability of the patient, whether the patient could afford a construct or not. So again, just 5 screws. You can see so many. Right. So this is 2 level up and 2 level down. The long construct, or the long segment fixation, because the patient could afford the screws. Right. So lots of cases. This is the case of fracture dislocation of a patient. Just to show you, I can see the CT, the X-rays and the CTs, fracture dislocation. This is MRI. The bilateral power was 1 out of 5 and 2 out of 5. 1 out of 5 in left side, on the right side 2 out of 5. Incomplete neurology. So you can see this is the posterior fixation is the only practical or the possible fixation type in my practice, because anterior fixation is not possible, because I haven't seen an anterior fixation plate actually for the last 5 years, and it's not available. And we don't have the expandable corpectomy cages for the anterior procedure. So at the same time, for the lumbar spine, anterior lumbar interbody fusions, extreme lateral or oblique fusions are not possible in my setup. So the posterior is the only option for this type of things. So I had used, I had few T-leaf cages. So I used a T-leaf cage for this patient. It's a young patient, to get more fusion, as well as to it was easier for the reduction purposes. I have done several cases like this. So this is another case, a complete fracture dislocation. Again, T-leaf cage was used. So just some innovative idea. Just to show you another case, this is a female, 54 years old female, presenting with this large tumor of the lumbar spine. You can see it's a very large tumor, filling almost the whole paraspinal muscles of the left side, and going through all the way up to the kidney and the Gerota's fascia. So ideally, it would have been a multidisciplinary team approach, but as a neurosurgeon, my objective was to get rid of the thecal sac compression. So this is her before surgery. Very difficult in mobilizing, had difficulty in standing up even. This is an intra picture. So I was able to completely, near totally, take out the tumor. So, and considering the sin score, the stability wise, and considering the primary tumor control, and we looked for the secondaries, and we discussed about the life expectancy of this patient. So considering all this with the liaison of the oncologist, so I went ahead with the surgery and went ahead with the fixation as well, because the pedicles were involved and I had to remove the pedicles as well. So we did the fixation from L1 to L5. She could afford only 6 screws. So that's why unilateral fixation on these pedicles were done. And this is her in clinic 2 weeks back. She's walking now, and the tumor proved to be a high-grade leiomyosarcoma, and she is now under the oncology follow-up for the treatment. Again, just to show you another case of interesting case of a posterior fossa tumor of a young male, 18 years old male, who presented with this big tumor, and we did the complete resection. I don't have the navigation facilities in my hospital, so ideally this type of surgery would have liked to do with navigation, but it doesn't mean that you should not be doing these cases. So we did the case, and this is the post-op CT. We completely removed it. This is the MRI images of the tumor. It's a big tumor. This is the post-op. I would like to show you actually the video of this one. So let's check whether we could see it.
Yeah, take your time. We have lots of time.
Sorry.
Take your time. We have lots of time.
All right. Okay. Thank you.
No problem.
Sure. Yes. Unfortunately, I could not edit these videos, but I will try to show you the important aspects so you can see the important steps and what was going on. So this is the craniotomy we did, the posterior fossa craniotomy, all the way from the inion down to the forearm and the magnum. Then open the magnum to release the CSF. I'm having a very limited armamentarium, very limited instruments in my armamentarium. And to be honest, the scissors are not cutting. The fine scissors are not very sharp enough to cut. And I'm having only one, what you call these dissectors. So anyway, you have to use, you have to get the maximum use of what you have. So it's not a complaint. So that's how the things are. So the occipital sinus is ligated. Sinus is ligated. And the exposure, the adequate exposure is obtained. So this is a transvermian approach to the tumor. So you get the approach through the vermis, the middle part of the vermis, making sure not to go in the most superior aspect of the vermis. And then you get into the tumor. You identify the tumor now, try to debulk it. Very vascular tumor, get a biopsy and send it for histology early. That's the tumor. Now I'm used not to use the CUSA because most of the times it's out of order. Now I have used operating without the CUSA, only with the diathermy and the sucker and the micro scissors. I like the sharp dissection most of the times, but this tumor was very, very vascular, and I had to use the diathermy, the bipolar most of the time. So the debulking was continued.
Are you okay, Sarath? I can't hear you.
Can you hear me now, Joe?
Now I can hear. Yeah.
All right, sorry about that. So the debulking was continued. It was a very highly vascular tumor. And finally, the margins were identified and the complete resection of the tumor was done. So had to be very precautious and very careful on this young patient, because if you are embarking on this type of surgery at your center, or you had to be very extremely careful and extremely precautious not to harm the patient, because you are not using you don't have the navigator as well, and you have to be very careful. You know, the high technology is not an essential part. It is to make your life easier, because in the past, all these surgeries were done without all these navigators and all. But nowadays, these things are available. So you should be precautious and you should be careful not to harm the patient if you don't have the facility, because you had the option of sending the patient to a center where the facility is available. So now you identify the margins of the tumor. And once you identify the margin, and once you devascularize the margin, then you can take the tumor out. So this took about 1.5 hours, the debulking and the complete resection, the procedure. So now you have devascularized it, you have detached the tumor from the surrounding, and now you can carefully take that out without pulling. There was a blood vessel there. So the rest of the tumor was removed, so you could see the brain stem. And so the tumor was removed completely. So patient had a very good outcome. This is another case I did yesterday. This case was done yesterday, just to show you, in some cases, you are left with no option. For example, this is a 60-year-old female who is working as a housemaid in a nearby house close to the hospital. And she presented with this subarachnoid hemorrhage with severe headache a few days back. And we did the CT angiogram. The CT angiogram said that is positive for a anterior communicating aneurysm, probably, but that was not clearly visualized because our CT machine is not doesn't have a very good resolution. Is actually a 16 sliced CT machine, an old one. So most of the time you do the CT angios, the CT angios becomes negative. It comes as negative. So you send the patient to another center, then it becomes positive. So most of the time the CT angiograms are negative. So what I had to do, I had to send this patient to a different center, or to, if the patient could afford, to the private sector to get the DSA or the CT angiogram done. So sometimes the 3D reconstruction is not possible. So sometimes the CD reconstruction is possible. Then at least you see where the aneurysm is, even though you cannot see the projections and the perforators and the adjacent vessels. It's very difficult to see them, but at least you know what it is. But in this case, it was not even possible. But the issue was this patient was reluctant to be transferred to another center because she didn't have, she had no one to take care of. So she's working as a housemaid. She has no one to take care of herself. So she said, she pleaded to be treated here. So she asked me not to transfer her to a different center, because then she would go again. She would go against the advised. So she would leave against the medical advice. So I had to take the decision whether to let her go with this aneurysm or to operate her on. So you don't know where the aneurysm is exactly. You don't have a proper view, a proper idea of the proper 3D picture of the aneurysm. So I was in a dilemma. So I'm sure most of you as neurosurgeons wouldn't have in this situation. So it's a real difficult situation, but I decided to go ahead with surgery. So let's see how the things worked out. This was done yesterday. So let's see. Yeah, right. Okay. So I preferred the right side, and I preferred the pterional approach rather than the supraorbital approach because I was not sure of the characteristics of the aneurysm. I would rather prefer the supraorbital approach for ACOM aneurysms because I have done quite a lot through the supraorbital rather than the pterional. But you had to be on the safe side, so the pterional approach was preferred, and the right side was preferred. So tense brain, release of CSF, the opticocarotid cistern was opened to drain the CSF. That's the first step. Okay. Then the retractors, partial sylvian split. Usually, I don't entirely open the split the sylvian fissure for anterior communicating artery aneurysms. Only the distal split is enough. See the carotids there. See the optic nerve and the anterior cerebral arteries. Starting to see the anterior cerebral artery on the right side. Sorry that I don't have the edited videos. I had no time to edit the video. So this is the whole video actually. And you trace the anterior cerebral artery all the way to the anterior communicating artery. See the optic chiasm. And now you see the aneurysm. And now you are happy at least because you found the aneurysm. And you know there is an aneurysm now. The aneurysm is projecting anteriorly and inferiorly. So sharp dissection and the blunt dissection, wherever appropriate, was done. And A1 and A2 visualized. I will run through it quickly due to the time constraint. Initially, I thought this part was the aneurysm only. Separated from the adjacent brain parenchyma. Then only I realized that it was a dot aneurysm. So initially I clipped it. I clipped the outpouching. So I clipped it, and then I realized it was not the complete aneurysm. So the major part of the aneurysm was still intact. So I clipped the main part of the aneurysm as well. So this is how it went on. Everything was fine, and the contralateral, the A1, the carotids, the optic nerves were visible. Everything was preserved. So this is the post-op CT. This is the post-op CT today, and we have weaned off the patient. Patient's GCS is 15 without any neurological deficit. So there are certain things in your life as a neurosurgeon you had to take on as challenges. So challenges make you a better surgeon. But I'm sure this is not the routine. This cannot be done routinely. And it has to be under exceptional circumstances. Just to show you another case, very small tumor. The radiologist opinion was a low-grade glioma of the right frontal lobe. So in my setup, even though my hospital is the only tertiary care center for neurosurgical patients, I have only 4 beds for the entire female population in my province. So bed issue is a big problem for me. And the turnover speed is also less, the turnover rate is also less. So we have limited beds. So one issue is ICU. We don't have the ICU facility quite frequently, and bed issue is another problem. So this patient, I decided to do as a day case. Because of the bed issue, this patient surgery was postponed several times. So this is a very small tumor. So it was very difficult to localize the tumor without a navigator. As I told you, I don't have the luxury of navigator guidance, but this is how I did it. So I had to use the exact craniometric measurements. So I had to calculate it with the CT and did a mini craniotomy. You can see the opening. It's a very, very small craniotomy. It's just a few centimeters, like a burr hole, a little bigger than the burr hole, and I could be on the target. I was able to spot on the target, the lesion. So lucky enough. So the tumor was completely excised, Not just a biopsy, the tumor was completely excised. Looked like a glioma. So complete excision of the tumor was done. And see the post-op CT. This is the post-op CT. You can see the size of the craniotomy. It's very small. And we did it with a linear incision, less than 5 centimeters. And we discharged the patient on this within 24 hours. So again, you have to work and adapt under the circumstances. Let's talk about something on spinal tumors. A young lady presenting with a spinal tumor, a large one. junctional tumor, thoracolumbar junction. So you can see it's spanning over 3 laminae. So you had to do at least 3-level laminectomy for this patient. For the question was to fix the spine or not. So this patient could afford. So did a proper job since the patient could afford. So the tumor was completely excised and fixation done. Another case, a young lady with a C1, C2 tumor. It confirmed to be a meningioma. And this is the pre-op. She was power 1 out of 5 initially. And this is the post-op CT, post-op MRI, sorry, after 6 months. Near total, not near total, completely taken out. And this is her after 6 months. It was done with a hemilaminectomy, so fixation was not required. Unfortunately, I don't have the post-op CT for this patient to visualize that it was done with a very small amount of a very small laminectomy. And this is another tumor at the thoracic junction, C6, C71. So again, the problem, not the problem, the question was whether to fix this patient's spine or not. So this is the pre-op, the neurological level of the patient. Couldn't walk properly. Can see, walked with difficulty, and the surgery was done. Complete excision of the tumor done, and I did the laminoplasty. So a laminoplasty was done. You can see the laminoplasty there. We don't have screws and these tiny screws and the plates to fix the spine in laminoplasty. So we had to use the sutures. The routine, the regular sutures were used. One vicryl was used. So this is him post-operatively. Even before the discharge, this is post-op day 5 or 6 as far as I can remember. This was done actually 1 year back. Now the patient is absolutely fine. He brought me a bottle of Kithul Trekal also recently. That was his job. Right, another case, a young female with the upper thoracic tumor, proved to be a meningioma, couldn't walk, and now after 3 months, 2 months, she's walking with assistance. So good outcomes we are seeing. All these patients, again, a tumor at the junction. Again, a laminoplasty was done. This is her. All these patients could not walk. Now ambulating back to their normal life. So let's see a few cases of spinal meningioma surgeries. This is the upper thoracic tumor of that young lady. It was a meningioma. Identification of the correct level is the most important in thoracic spinal tumors, because you can easily mislead if you are not in the you are not at the correct level. So we don't have neuromonitoring facilities at my center. We don't have MEPs, SSCPs. We have nothing. So in spinal schwannomas, we try to preserve as much nerves as possible. So this is the meningioma. So I used to use a stay suture through the tumor and elevate it and ask my assistant to just apply a force upwards so I can see the margins, the inferior margins of the tumor. And the last bit, you completely take the tumor out and you datamize, so you coagulate the origin of the meningioma and the dura. So that's about meningioma. Let's see another spinal tumor. Let's see a schwannoma. Now I'm being able to show you at least the video, which is much more interesting, because you may remember when I was doing the first few presentations, I did not have the recording facility of my old microscope, so I was just showing you the pre-op CTs and the post-op CTs, and that's all, which was not really interesting. I do the minimal, the bone removal, the minimum amount of laminectomy which is needed. So this was a schwannoma. So as I said earlier, we don't have the neuromonitoring, so you try to preserve as much as the passing nerves. Identify the nerves which are originating where the tumor was originated and need to get rid of them. So I was trying to preserve all these nerves as much as possible, except the nerve where the tumor was originating. And finally was able to do a good job with preservation of all the important nerve roots. And finally, you identify the nerves needed to be sacrificed. Not very easy when you're having so many some small nerve roots. Finally, you take the whole tube out with good preservation of all the important nerve roots. Right, so this is it. That is this lady's spinal tumor, which was removed in that fashion. Finally, last slide. A case of intraventricular hemorrhage in a 70-year-old female with initially presented with a GCS of 12, which dropped to GCS of 8. So basal ganglia tumor with secondary extension into the ventricle. So I thought, rather than inserting an EVD as we do routinely, taking the ICH out, taking the IVH out, through the burr hole where we used to insert the VP shunt. So this is the mini craniotomy or the burr hole, and initially you put the EVD through that, and you obviously you see the clotted blood coming out, and you use the EVD as a guide. You use the EVD as the guide and go through it. And now you are in the ventricle. So let the clot come towards you. Be very careful. Inside the ventricle, you need minimal handling. Now you can remove the you can remove the EVD because you are already inside the ventricle. And this is the thalamic ICH. She's being evacuated now. Minimal coagulation with diathermy. Obviously, you can't take the whole clot out because the distance is too much. So you're going to do a maximum safe resection, a safe excision, a maximum safe evacuation of the blood clot. And then you achieve the hemostasis ultimately. Right. So this is what we achieved. So you can see the third ventricle is obstructed, the fourth ventricle is blocked. Before surgery and after surgery, you have got rid of the basal ganglia hematoma, and the third ventricle is open now. The fourth ventricle is open. And this patient went home. This is a 70-year-old patient, and she improved over a period of 6 weeks. Although the post-operative period was complicated by pneumonia, we had to do a tracheostomy on her, but she recovered well and she went home. As we all know, the mortality and the morbidity of intraventricular hemorrhage is high, with a high mortality, especially in our part of the country, in our part of the world. But this led to a good outcome. So yeah, it was an interesting option for me. Right, so that's all I have to show you. So I hope I have given you some tips and few messages, especially for young neurosurgeons, as take-home messages when you are working under difficult circumstances in a remote area where you have not much choice, but you are in charge. It's your responsibility. So you should be answering all the questions and the issues. Sometimes the litigations, fortunately, the amount of litigation in our country is not that significant yet, but I'm sure there will be more and more legal aspects, legal issues coming up in near future as well. So you have to be vigilant. You have to stay focused as neurosurgeons. So all these things we need to keep in mind and provide the maximum, provide the best quality care to the patient. So it has to be a patient-centered, empathetic, patient-centered practice rather than a lucrative practice, rather than a money-oriented practice. So I think always think about patient safety and always think about patient outcome, which is the utmost and the priority as a neurosurgeon, especially when you are working under difficult circumstances. So whatever you do, however much you do, if the patient's outcome is not good, if the patient's outcome is poor, there is whatever you do, there is a question about the value. So your attitude is very important. It should be patient oriented. It should be towards patient safety and patient outcome. So if you if you go ahead, if you follow the principles of neurosurgery wherever you are, and you adapt or you adjust your techniques and your decision making and your procedures according to the principles, and you are performing safe surgery, I think one day you should be rewarded for what you have done under difficult circumstances, which is extremely satisfying, rather than working with the assistance of high technological assistance. So that I can assure you as a neurosurgeon with experience in practicing in remote areas. Thank you. Thank you, John, for giving me this opportunity. I hope I can show the world that we are doing some good work, even with the minimum of resources. Thank you.
Yeah, thank you, Sarath, for showing us your part of the world in neurosurgery, taking the time, a well put together presentation, and you oriented us to the exact problems that you have, like scissors not being sharp and not having, diagnostic capabilities, navigation. But I'll let neurosurgeons comment more on that. And it looks like Halal Najar is here. Perhaps he'd like to comment. Welcome, Mr.
Thank you very much. Good evening or good morning. I don't know the time. Thank you for your kind and beautiful presentation. I want to ask you for how long you are practicing in neurosurgeon as a specialist or consultant?
This is my sixth year as the board certified neurosurgeon.
16?
Six years.
6 years. That's
Yeah.
it. Yeah.
5
Okay.
plus.
Actually, the address of the subjects encouraged me to attend this. I'm practicing in Syria, and I'm practicing neurosurgery since 1995. And I did my fellowship in 2000 with Professor Yashar Gil and Professor Usama Al-Mifti in Arkansas, in Little Rock, in United States. Anyway, I think it's a very, if you give me just 2 minutes to explain my idea. When you attend many new updating meeting and congress, you feel it's very difficult to bring these facilities to your OR. For example, we are practicing in the Middle East, and you are in Sri Lanka and Pakistan and India and the third world. Maybe we are in similar situation. Actually, these very sophisticated systems like intraoperative MRI, which now in the Gulf area, which is very rich people, they have rich people, they have maybe 3 or 5 until now. In United States, maybe they have just a few, not all the states and the hospitals in United States. On Europe, they have intraoperative MRI. For example, we don't have intraoperative MRI, we don't have navigation, we don't have even intraoperative mapping. We just have a drill and microscope and forceps for bipolar, and that's it. And when you see Professor Yashar Gil did his major cases and most insular tumors and most, let's say, the brainstem tumors without any this new high technology, this will convince you that the main point is the anatomical dissection of the workshops and the training that you do it in the lab. That's it, because he spent 2 years in the lab. So he did everything without, maybe he just used the navigation in this, maybe after 2000 or maybe the end of the 19th. That's it. So we should not depend on the high technology, because we don't have it. It's very sophisticated and very expensive, and not all the centers in the West actually they have it. This is something dreams for us. What can we do instead of that? For example, we can use endoscopy for hydrocephalus. Is cheaper than doing 10 operations for shunt replacement and shunt infection. For example, the posterior fossa, you have in your lecture. If you do it by neuroendoscope, I did my first cases with pediatric nephroscope, and you can do it ETV, and your patients will be free of shunts, because he might have radiation and chemotherapy. So every complication of the shunt he will have. If you can avoid your patient of posterior fossa tumors or any kind of obstructive hydrocephalus of shunts, it will be a great idea. The other points, we did the first cases of spinal fixation, 1994. We don't have any pedicle screw fixation at that time. We just use subliminal wires, Rwakami, Harrington, the old one, and then we use pedicle screw. We use orthopedic molar screws and just tibial blades for maybe 1 or 3 or 2 years, and after that the companies become available in my country. So we can do it in our limited resources. We can do a good job. We can do a very good cases with good results, just if we stuck to the main source of science for the surgeon, which is the hands-on workshop. This is, I think, my important idea. And thank you very much for your time.
Thank you very much. 100% agree with you, and very inspiring. Thank you for sharing your experience with us, Dr. Dalal.
Very good. Very good. Any more comments from the panelists? If not, I just have a comment. I'm not a neurosurgeon, but I saw that you have so many spine cases, thoracolumbar, which I think the general neurosurgical practice maybe has a few cases a year. I would think that a neurosurgeon watching that wants to specialize in spine would say, hey, I'd like to be there. They get so much experience with spine cases. Sure, you have a lack of some things, but as you know, a neurosurgeon experience is valuable. And if they can do a lot of cases, are you interested in getting fellows there or people to work with you, or what's the status there, Sarat?
I mean, officially, I'm actually officially, we cannot get the fellows.
Oh, you can't, okay.
But I mean, personally, they can.
Even non-paid,
Yeah, I
people
mean,
or
they can just visit and they observe whatever it's being done. But most of the time, we had to get the permission through the institution. And there's a procedure. Yeah, I mean, they can personally contact me, and that is not impossible. Actually, more than 60% of my work is spine because it's like a spine center. Lots of spine cases are there, as I said, because of so many road traffic accidents and fall from heights. So many
Yeah.
interesting spine cases we are doing, even though we have limited resources. So it's actually a very good experience for a beginner.
Yes, I would think a young neurosurgeon, of course, loves a scalpel and it has to get experience. At a normal center, you probably don't have that many thoracolumbar fractures.
Yeah.
Normal neurosurgical practice. Anyways, I think there's a niche for people. So yeah, I'll keep that in mind if I see a young spine neurosurgeon that complains about, I'm not getting much experience, etc. I'll try to remember that and refer you them.
Yes, I
Okay,
agree.
anybody?
I agree for that. That the cases, a large number of cases and patient. This is the goal for you. Just you must document all the cases, and when you have your documentation, you can put it in the lectures and the meeting. I forgot to tell you something. I am working now on the border. We in the new center. We have a microscope, and I have many cases, but I don't have video camera for the taping all the of all my cases. I do it. So I just went to have used Sony camera video camera and attach it to the microscope and record it as you use it for any recording any unusual. And I put it in meetings, and its photos. It's really fantastic. But if I did not make this, which is cost me maybe $200 for used video cam, but I document about more than 200 brain tumors, and I have a series of 34 of Janetta microvascular decompression of trigeminal neuralgia. And this is a very rare cases. So with the simple tools, you can just document your large cases and your experience for you and for the residents and for the meeting. Okay, thank you very much.
Thank you.
Thank you. Thank you. Okay, more comments or questions from any of the panelists? Can you hear Das Gransham from China? Can you hear us? I don't know if you're still watching. And there was one Russian resident, maybe he stepped away. At least, where did he go? Perhaps he's not here. Okay, well, very good, Sarath. I'll keep that in mind about referring you people that may want to just come for one. You know what IPE does? The residents go for 1 month. One month, and I would think a spine person that wants to learn about thoracolumbar spine would love to see so many cases. And actually, what's the procedure? Again, I'm not a neurosurgeon. If you had an unpaid fellow at the hospital, is it a big procedure to let them operate?
Actually, I'm not very sure, John. I think I need to check that out. I'll let you know. I'll contact you. I'll keep in touch.
Okay. Just to know. Okay, then we think we're going to do one in 2 weeks. We'll let everyone know. As you know, it's the upcoming holiday season, and I've tried to do a lot of webcasts, but it's tough sometimes. But we'll see. We'll keep in touch and let the neurosurgical world know. We have a couple of, let me just do some commercials here. We have a big conference. I think we're going to have some spine. Let me just get it up on the screen. Just give me a second. We have a lot of neurosurgeons there. Let's see here. Okay, here we go. Let me just screen share this. This is put together by Sam El Morsi from Egypt. He's a neurosurgeon there. He's the organizer. James Leo, Abderov, Borba, Louis Atul, Atul, you know, he's a big spine guy. I'm sure you know him. And lots of top neurosurgeons tomorrow, or actually at 10 o'clock, let's see, 10 o'clock Cairo time. In India, I believe that would be around 1:30 or 2 in the afternoon. So if you're free, come and see us. If not,
Sure.
we'll probably see you in 2 weeks.
Yes.
Thanks again, Sarat.
Thank you,
Thank
John.
you.
See you then.
Thank you.